I'm going to be talking about oral cleansing products that we use and recommend for our patients. As we understand connections between periodontitis and oral systemic health, we need to recognize there are alternative therapies that help focus on reducing inflammation using mechanical devices and chemotherapeutic agents. Oral inflammation has been linked to stroke, heart disease, increased inflammation with diabetes. Some of these conditions can make a person more susceptible to periodontal disease. Oral pathogens can travel to the lungs and cause aspiration pneumonia. All of these connections make it so important that we find good products to recommend for our patients to reduce bacteria count and control bacteria within the oral cavity. One thing that I like to mention at the beginning of this lecture is we're talking about dentifrices. We're talking about toothpaste. Dentifrice, fancy name for toothpaste. A board question that's very popular is to name the 3 mechanisms of action for dentifrices. Those are remineralization, reducing the solubility of enamel, and bactericidal and bacteriostatic effects depending on the concentration of fluoride and active ingredients. Dentifrices themselves can be preventative, therapeutic, or cosmetic. They're applied with a toothbrush for removal of biofilms, stains, soft deposits, and superficial cosmetic effects. They help to prevent caries. And the primary focus for hygienists, we are the prevention specialists. So the products and the dentifrices and the ingredients are very important for us to know so we can make good recommendations for prevention. Xylitol is a non-cariogenic sweetener that has been shown to have anti-caries effects. It facilitates remineralization. Fluoride is recognized as an anti-caries agent. And that's the most important part about a toothpaste with baking soda or xylitol. Baking soda, there's really nothing about it that's therapeutic. Research began in the 1940s to add fluoride to toothpaste. The first caries prevention toothpaste was a 0.04% stannous fluoride. Fluoride toothpaste was commercially available in 1955 with stannous fluoride in it. It had tin in it. Stannous fluoride has tin in it, and it lacked compatibility with the abrasive agents in toothpaste, and stain was a pretty common complaint. So stannous kind of has a bad rap for causing stain in the early days. Crest had the first provisional seal of acceptance from the ADA in 1960, and there was full acceptance in 1964. Early toothpaste was restricted to low fluoride amounts. Those low fluoride amounts were up to 1,200 parts per million, and they had to have safety caps. The level was raised when AIM was introduced, and that raised the fluoride level to 1,500 parts per million with AIM. Most over-the-counter toothpaste is 1,000 to 1,500 parts per million. There is a prevalent prescription toothpaste that is 5,000 parts per million that would be recommended for patients with rampant caries, patient with evidence of root caries, and caries with orthodontic treatment. It would not be given to a child under 6, so it wouldn't be given for early childhood caries. There are 3 types of fluoride that are typically used in fluoride, or 3 types of fluoride typically used in toothpaste or dentifrices. Sodium fluoride, sodium monofluorophosphate, and stannous fluoride. The concentrations of these fluorides typically are stannous fluoride 0.04%, sodium fluoride 0.022%, and sodium monofluorophosphate is a 0.076% fluoride. All of those different combinations all equate to 1,000 parts per million. So the 0.04% stannous, 0.022% sodium fluoride, and the 0.076 sodium monofluorophosphate all equate to 1,000 parts per million. Mentadent was a baking soda peroxide toothpaste that was a stable peroxide gel with baking soda. That was 1,100 parts per million. It was a 2-pump package that mixed the baking soda and peroxide with fluoride at the time of delivery, all with just 1 pump. That low level of peroxide claimed to be safe. In general, for fluoride, the maximum caries inhibiting effect occurs when there is systemic exposure before tooth eruption and frequent topical fluoride exposure throughout life. So maximum caries inhibiting effect occurs when there is systemic exposure before tooth eruption and frequent topical fluoride exposure throughout life. Fluoride in general is used for prevention of caries and remineralization of early incipient lesions. When we talk about the baking soda toothpaste, there's nothing therapeutic about baking soda. Fluoride is the best or most effective ingredient in a toothpaste with baking soda. Stannous fluoride is an ingredient that was in initial products. It proved to be unstable. The original Crest had stannous fluoride. It was in the toothpaste that got the first provisional seal of acceptance. It's good anti-caries fluoride, not significant with reducing plaque or gingivitis. In the 80s, Crest switched to sodium fluoride, and that's what's in most of the Crest toothpaste. They've continued to work on toothpastes containing stannous fluoride, and Crest Pro Health has stannous fluoride. It, like I said, it has been shown to, or has gotten a bad rap for causing extrinsic stain due to the stannous ion, but that was early days. The current product, Crest Pro Health, has stabilized stannous fluoride, and it's has a superior efficacy compared to the previous products. So they've found a way to bind that stannous fluoride and it doesn't stain. They have added sodium hexametaphosphate for tartar control and whitening, and it kind of counteracts that staining from stannous fluoride. Triclosan, zinc citrate, and stannous fluoride all prevent attachment of bacteria to tooth surface and decreases biofilm formation. Triclosan is a primary agent to decrease gingival inflammation and have substantivity. Substantivity means it goes where it's supposed to go and it does what it's supposed to do. Triclosan prevents gingivitis and it shows efficacy, so it produces the desired results. And when combined with a copolymer, increases substantivity, stays in the area where it's intended for up to 12 hours, even after eating and drinking. It kills oral bacteria, decreases supragingival calculus formation, it decreases biofilm, and it decreases bleeding on probing. Triclosan is also an ingredient in antibacterial and antimicrobials that was banned from soaps in 2016 and 17. Studies have shown that it's okay in toothpaste. I have a little blob here. Mom blogs link Triclosan to be an endocrine disruptor and suspected carcinogen. The FDA banned the chemicals used in antibacterial liquid soaps in 2016. Banned it because companies failed to prove Triclosan was safe. The FDA's ban was limited in part because of the way those products are regulated. Colgate eliminated Triclosan from its toothpaste, but when it came to toothpaste, the agency said the potential benefits of Triclosan outweighed the risks, a decision that baffled some scientists and consumers. Colgate Total has been the only toothpaste approved for sale in the US that contains Triclosan. Tartar Control has been popular and on the market since the late 70s. Tartar Control toothpaste retard calculus formation. The American Dental Association doesn't approve toothpaste for tartar control, only approves it for the fact that fluoride is in the toothpaste. So here's again an effective ingredient for reduction of gingivitis, 12 hours of substantivity when it's combined with copolymer ingredients, reduction in suprabiofilm, reduction in inflammation, and Tartar Control toothpaste in general, late 70s on the market. 1985, P&G supplemented their current product, and that's the Tartar Control toothpaste. These retard calculus formation, but it's approved only, the Crest Tartar Control is approved only for the fluoride and anti-cavity properties in it, not for the decrease in calculus or the Tartar Control properties. Aim and close-up Tartar Control use zinc citrate for Tartar Control. This ingredient does not inhibit the action of fluoride. The ADA doesn't consider calculus inhibition as therapeutic. Tartar Control toothpaste will include some ingredients such as pyrophosphate salts, zinc salts, so zinc chloride or zinc citrate, sodium hexametaphosphate, and triclosan. Those are the ingredients that would be found in a Tartar Control toothpaste. Antihypersensitivity, 5% potassium nitrate is the best sensitivity ingredient. We don't want a patient to use potassium nitrate for longer than 4 weeks because it could be masking more of a problem. So it takes about 2 weeks for a sensitive toothpaste to work and start working and occlude or block the dentin tubules that would cause the fluid shift into those open porous areas of the tooth on the cervical of the tooth. We don't want patients to use it for longer than 4 weeks and be masking maybe a large cavity, an abscess, an area of infection. The active ingredients in our sensitivity toothpaste are potassium nitrate, which blocks nerve conduction and depolarizes the area with potassium. Potassium nitrate is in Prevident, it's in Crest sensitivity toothpaste, it's in Sensodyne, Floridex, and Colgate sensitivity relief. Strontium chloride is in Sensodyne, and that blocks the tubules, blocks the dentin tubules. It's a self-applied fluoride, and we usually like a patient to have diet changes that would also help with the strontium chloride toothpaste blocking the tubules. So these are the active ingredients in sensitivity toothpaste. The ADA approved Sensodyne for both anti-hypersensitivity and caries prevention. This is the first toothpaste that solved 2 problems and that was recommended to be used for 2 problems. Polishes and whiteners. Whitening toothpaste reduces extrinsic stain from coffee, food pigments, tobacco, or chlorhexidine use. They are mid-range in abrasivity. They have some peroxide ingredients, so they can have a 1.5% hydrogen peroxide or a 10% carbamide peroxide. The carbamide breaks down into urea and hydrogen peroxide, and the O2 is the active bleaching molecule in carbamide peroxide. Whiteners, if there's overuse or regular use, they can cause overgrowth of yeast, which could lead to black hairy tongue. There could be damage to the pulp. Whitening toothpaste could damage soft tissue, cause sloughing of the soft tissue, or delayed wound healing. So we want to watch for sensitivity from whitening. We want to watch for whitening, people using whitening toothpaste too much and causing some of the other issues. FDA wrote a letter to companies and classified these toothpastes as drugs, and they want manufacturers to look at long-term effects. There are a lot of products out there that claim to be whiteners, and there's not one definition. And Toothpastes aren't in contact with the teeth for very long, so they rely on the abrasivity of the toothpaste to whiten, so they can cause sensitivity. And the FDA wants these products to be studied and looked at for long-term effects. There's a relative dent and abrasivity schedule, and you guys have a project that is due next week that has you looking at the relative dent and abrasivity of your toothpaste, has you looking at your toothpaste, how it got approved, the FDA approval process, the active ingredients in your dentifrice, what all the different ingredients do. So you guys will be going a lot into the oral products. Mouth rinses. In 1999, this was approximately a $656 million business. Alcohol is in a lot of the mouth rinses, so we need to watch mouth rinses for xerostomia, and we need to watch mouth rinses for children or potentially for previous alcoholic patients. Mouth rinses can be preventative with fluoride, chemotherapeutic. They can have active ingredients to reduce inflammation and caries and prevent periodontal disease. We use mouth rinse as a pre-rinse to reduce the bacterial and aerosol contaminants when we're working. There is a lot of advantages to self-care home rinses. We do need to take a look and make sure that we are advising patients well for the mouth rinses, because 5 to 10 ounces would be lethal for a child that was 26 pounds. So a lot of poison control calls go in for children using mouth rinses or swallowing mouth rinses that have fluoride in them. There have been children who've died. There have been permanent injuries from overdose on fluoride from the mouth rinses. So the American Academy of Pediatrics recommends that safety caps are on all of the mouth rinses, and it is kept to a reasonable minimum to prevent the potential for lethal ingestion. So we've got our fluoride rinses that are typically maybe 100 parts per million, 225 parts per million, up to a potentially 900 part per million used on a weekly basis. So we want to keep them out of the reach of children. Obviously, we want to recommend that they are not swallowed. They contain alcohol. Research from the National Center for has linked alcohol mouthwash to mouth and throat cancers. So we want to make sure that we're advising well when we're recommending mouth rinses. Cancer patients are more likely to have rinsed regularly with a higher alcohol mouth rinse. Alcohol may or may not have been implicated for the cancer in and of itself. Is it causative or is it correlation? So it can promote the disease by dissolving and dispersing other cancer substances in the mouth and throat. The preprocedural rinse reduces the bacterial count while we're working. So if we just had them rinse with water, there's a 61% reduction. If there's brushing alone, there's 85% reduction in the bacterial content of any aerosol. If we have them rinse with that antibacterial rinse, there's a 97% reduction in bacteria. So that's why we have them rinse with this preprocedural rinse. Halitosis is a common problem for our patients, and they want good products that help with halitosis. So more research is needed. 95% of the bad breath comes from the mouth. 3 to 5% occurs from stomach issues and that kind of thing. There are volatile sulfur compounds that are released from bacteria on the tongue. higher amounts in patients with periodontal disease because that's an infection. So there's bacteria that are more virulent and gram-negative bacteria that are producing volatile sulfur compounds. And there's a higher amount of bacteria and bad breath on the back of the tongue. So we want to make sure we're talking to the patient about tongue brushing if necessary. So here's where the volatile sulfur compounds contribute to oral malodor, and some of the oxidizing agents and mouth rinses will work on those bacteria, neutralizing those bacteria. Other products can include essential oils, zinc chloride, triclosan, or stannous fluoride with hexametaphosphate to combat halitosis, as well as the cleaning of the teeth and reducing oral bacteria and cavity fighting properties. Fluoride rinses can have stannous fluoride, sodium fluoride. The sodium fluoride prevents caries, reduces hypersensitivity, reduces gingivitis. Chlorhexidine is the preprocedural rinse that we use. And chlorhexidine is a product that is a 0.12% chlorhexidine. Paradex is name brand. It's bactericidal, bacteriostatic. It disrupts cells' osmotic equilibrium, resulting in death. It's the most effective anti-plaque agent to date. It stains, so long-term, we don't want patients to use this long-term. It can alter the taste, so it can alter patient's taste, and it can be a minor mucosal irritant. The SLS in toothpaste inactivates when chlorhexidine is used right away after brushing. So we want to wait 30 minutes before chlorhexidine is used. It has substantivity. It sticks to the pellicle. It does what it's supposed to do, which is reducing bacteria. Binds to hydroxyapatite, inhibits colonization of bacteria, and it slowly releases its active ingredients over an 8 to 12 hour period. It should not be used right before or after brushing because it's inactivated by the toothpaste surfactant, the SLS, and it's not effective against all anaerobes. Stains the most common side effect, altered taste. It actually increases the calculus formation on the teeth. So it's good for reducing the bacteria count, but there is an increase in calculus formation. Desquamination or sloughing of the tissues is common, and some sensitivity is common. There is a non-alcohol and alcohol-containing version. It's a broad antibacterial activity, bactericidal, bacteriostatic, antimicrobial, anti-gingivitis. Post-surgery, it's great for wound healing. Pre-procedural, it's great for reducing the bacteria count. Before and after periodontal debridement, used in the Canberra process to reduce the strep mutans for caries causing bacteria. Listerine, we should make sure that we use Listerine alcohol-free for a recovering alcoholic. It has in between 21 to 26% alcohol in the original formulations. ADA approved Listerine phenolic related essential oils, thymol, menthol, eucalyptol. They approved the mouth rinse for anti-plaque and anti-gingivitis properties. There is a burning sensation, there is a bitter taste, and it is contraindicated for recovering alcoholics, but there is an alcohol-free version. So Triclosan, there's no rinse available in the US, only the Dentifrice, only the Colgate Tartar Control toothpaste has the Triclosan, or Colgate Total Tartar Control. Quaternary ammonium compounds, so our acetylpyridine chloride reduces bacteria's ability to attach to the pellicle. There is an increase in supragingival calculus formation. Can stain the teeth, and this is in the Crest Pro Health Rinse. Home irrigation products, professional irrigation products have to be supplemented with home use for full effectiveness. So subgingival penetration of different tips, like water pick tips, when the tip is placed Super G, it can get to 44 to 71% of the pocket depth. If there's a specialized tip that goes with the irrigating product, that can penetrate 41 to 90% into a pocket. Effectiveness of antimicrobials are enhanced by oral irrigator delivery. So after scaling and root planing, if a whole mouth disinfection is done in the office to just rinse and flush those pockets out, it's nice to send them home with some chlorhexidine or an antimicrobial to irrigate with at home, to put in their water pick at home to irrigate down in the pockets and get to up to 90% of the pocket depth. FDA testing and approval. We have or I should say I have a Prezi that goes through the FDA testing and approval process and the different phases of that. Preclinical, using animal testing for safety and toxicity effects. Phase 1 is a very small sample. Phase 2 is a little bit bigger on people who have the disease that we're looking at, so periodontal disease or caries, fighting, depending what we're looking at. Phase 3 is 1,000 to 3,000 with the disease or condition. Phase 4 is trials on products already approved on the market. So we can take a look at this on the Prezi. And that's it. Thanks for your attention. Good job, guys.